Vitayu. Good afternoon to everyone. We still have a few people who are logging in, so we're going to give them a few more moments before we get underway with the lecture by Dr. Zatmari. Okay, perhaps we'll get started. Good afternoon to everyone. Thank you for joining us for today's webinar, Managing Acute Stress, Anxiety and Depression in Children. My name is Dr. Miroslava Romach. I'm a psychiatrist, and I'm also the co-director for the Ukraine Pediatric Fellowship Program, which is situated at Sick Children's Hospital, Sick Kids Hospital in Toronto, and I will be acting as the moderator for today's webinar. The webinar series is an initiative of the Ukraine Pediatric Fellowship Training Program, a program supported by Sick Kids to promote the quality of pediatric healthcare in Ukraine in selected children's hospitals. This program celebrated its 10th anniversary last year. This particular series of webinars was organized in collaboration with our Ukrainian colleagues in our efforts to provide ongoing training for pediatric physicians while recognizing the difficult and unique circumstances within Ukraine's healthcare system today. Before we get started, I would like to go over a few housekeeping rules about the webinar. Firstly, the webinar will be recorded and will be made available on a YouTube for those who are unable to attend live. There is live interpretation between English and Ukrainian. If you click on the interpretation button, which looks like a globe on the bottom of your screen for the language of your choice, you can use or you can ask questions at any time using the Q&A function on your screen, We will try to respond to as many questions as we can in the time that we have. But if your question is not answered or you have any additional questions, please feel free to send them to our colleague, Laura Lewis Watts. Laura has added her email in the on the screen, and we will do our best to get to as many as we can today. So I would like to begin by introducing our speaker for today, Dr. Peter Jatmari. Peter is a leading pediatric psychiatrist, and until 2021 was the chief of the Child and Youth Mental Health Collaborative between the Hospital for Sick Children, the Center for Addiction and Mental Health, and the University of Toronto. He has worked in the field of child psychiatry for over 40 years in the areas of attention deficit, hyperactivity disorder, depression, anxiety, impairment due to mental disorders in children. Currently, he's the director of the Kundal Center for Child and Youth Depression at the Center for Addiction and Mental Health in Toronto, a center that's dedicated to global leadership in the field of child depression. Peter, welcome and thank you.
Thank you very much, Miroslava. It's great to be here. I hope everyone in Ukraine is safe, and I want you to know how much we in Canada, and I know many of my colleagues think of you. We're obviously very concerned about all the young people in Ukraine and all the exposure to violence, and anything that we can do in order to make their lives better, we're certainly committed to doing. I'm part of a Lancet Commission on rebuilding the mental health system in Ukraine, along with many Ukrainian colleagues that I've had the great pleasure and honor of meeting in the last year or so. And one of the important messages from that commission is the importance of collaboration with health professionals outside of Ukraine and working together. And I hope this is the start of a longstanding collaboration between the Kundal Center, the Sick Kids Fellowship Program, the Pediatric Fellowship Program that Miroslava runs, which is such an amazing program, and colleagues in Ukraine. I'll just mention that for my talk, I'm really going to focus on depression as opposed to, but I'm going to touch on anxiety and stress and post-traumatic stress disorder as we go along. But I'll focus on depression because there's so much material to cover. Next slide, please. Just my financial disclosures, conflicts of interest. I get royalties from 2 books that I've published from Guildford Press and Simon & Schuster. I receive funds as director of the Kundal Center, and I get funding from the University of Toronto. Next slide, please. My objectives today are really 2. First of all, I want to highlight the poor treatment response rate that youth with depression experience in different treatment programs. And I want to make the argument that to improve treatment responsiveness, we have to realize that youth depression is a complex problem requiring a complex solution. And I think that solution is that we need to personalize the treatment approach. Next slide. First off, what is depression in children and youth? It is both a dimension, that is a spectrum of symptoms and psychopathology, but it's also a categorical disorder as defined in DSM or ICD. And it's defined by a symptom constellation along with some distress and impairment in functioning. The clinical presentation of depression in young people is very similar to that in adults, but there are 3 major differences. The first is that depression changes with development. There's a sharp increase in prevalence over a very short period of time post-puberty, and I'll illustrate that in a moment. The second thing is that the response to treatment in youth depression is much poorer than it is in adult depression. And thirdly, there is a lot more comorbidity of other mental disorders with depression in young people than there is in adults. Next slide, please. This is just a brief summary of the DSM-5 criteria for depression. The ICD-11 criteria are very, very similar. There are 9 symptoms in total, and you have to have 5 of those 9 symptoms over a 2-week period being present for nearly every day or, almost all of the day. The 2 key symptoms, you have to have at least one of these 2 is depressed mood or irritability in young people, very commonly, and then what we call anhedonia, a loss of interest or pleasure. So there are these 9 symptoms. I'm just going to go over them real quick. Depressed mood, diminished anhedonia, significant weight loss because of changes in appetite, insomnia nearly every day, psychomotor agitation, in kids more common than psychomotor retardation, again, nearly every day, fatigue, loss of energy, very important, feeling of worthlessness or guilt, diminished ability to concentrate, and recurrent thoughts of self-harm or suicidal behavior. A key addendum is that the symptoms, 5 of these 9 symptoms must be present for this 2-week period, almost every day, but there also has to be distress and impairment, that is difficulty in functioning, in meeting age-appropriate developmental expectations at home, at school, with friends, with family, in the community. Next slide. Oh, I've done that slide already, so we'll go to the next one. So I thought I'd give you some diagnostic pearls to help in the assessment of depression. And I really want to emphasize the importance of having an assessment of impairment in functioning, because this is a key differentiating feature from grief, from adjustment disorders, from stress reactions. And obviously in your community, in your country, a lot of kids are going to be exposed to violence and war, and they may experience grief and stress reactions, but they won't have impairment over an extended period of time, which is why the assessment of impairment is so important. I really recommend using validated screening tools that measure the severity of depression in individuals who are at risk and are coming through your particular clinic. We recommend the RCADS, the Revised Child Anxiety and Depression Scale, the Mood and Feelings Questionnaire, the PHQ for the adolescent version, and for screening for self-harm, the Columbia Suicide Screening Scale. I tried to check whether these were translated into Ukrainian. I don't think the RCADS is. I know the PHQ is, and I'm not sure about the others. I'll try and find out more information, but I'd be interested in learning from you if you use rating scales and which ones you do. Not all rating scales are of equal value. One problem that we have in child and adolescent psychiatry is that we have 2 informants. We ask the kid and we ask their caregiver or their parent, and very often they disagree. So there's a lot of confusion or some uncertainty as to about who to believe. I think in the depression field, and I think this is also true for anxiety, if the kid is over 10 years of age, give primacy to the youth and their self-report. If the child is under 10 years of age, give primacy to the parent. Self-report in children under 10 has very low reliability, so you can't really rely on reports from kids under 10 years of age. There's some red flags to pay real attention to when you're sort of doing a general screening. Sleep disruption is very common in kids with both anxiety and depression. And we know that that is a very high risk marker for depression. Any thoughts of self-harm? And if there's a pre-existing history of anxiety, ADHD, any form of trauma, any form of abuse, any form of loss, all these place the kid at very high risk of developing depression, and it should be a trigger for you to screen for systematically for the presence of depression and or an anxiety disorder. There are also special populations that are at very high risk for depression, and those are kids. I know that many of you work in children's hospitals, and chronic pain is common, but chronic pain is very commonly associated with depression. Other chronic medical conditions like lupus, like head injury, like sickle cell, all kinds of chronic physical conditions. Obviously, kids who have been exposed to the loss of a parent and are experiencing prolonged grief. And I would highlight autism as well, particularly girls with autism. Depression and anxiety and autism is a very common comorbidity, and we too often pay attention to the autism, and we don't recognize that those autistic girls also have an anxiety disorder and depression. The one thing I want to emphasize is that depression never occurs alone. This is very different than adult depression. Depression virtually always occurs in the context of another mental disorder, most commonly anxiety disorder and or ADHD. So if you see kids with anxiety and ADHD and they're in that post-puberty period, very important to screen for depression in those kids as well. Next slide. So I was asked to talk a little bit about acute stress disorder and PTSD. And there's a kind of a hierarchy in these conditions. So if a kid meets criteria for depression, that trumps, if you allow me to use the word, grief and acute stress disorder. So you can't have grief or acute stress disorder if there is depression present. But depression and PTSD can occur together. PTSD standing for post-traumatic stress disorder. Acute stress disorder occurs in the first month after a traumatic event, and there's no specificity to what kind of a traumatic event, but it's only in the first month. If it lasts longer than a month, then that's more likely to be PTSD if there are those symptoms of intrusive memories of the traumatic event or nightmares or some of the other signs and symptoms of PTSD. The treatment for PTSD is what we call it's cognitive behavior therapy, CBT, but it has a trauma component to it. So it's slightly different than the standard form of cognitive behavior therapy, and medications, and I'll talk a bit more about medications in a moment, are also effective for PTSD. Next slide. This graph illustrates the important sex differences that we see in depression prevalence and the age at which the prevalence of depression starts to go up. The red lines are girls, the blue lines are boys. So you can see that they're consistently, girls are at higher risk of depression than boys. The solid line is mild to moderate depression. The broken line is severe depression. So an important differentiation is mild moderate versus severe depression. And I think you can see the rapid rise over a short period of time, starting at between 11 and 14 years of age, where depression really starts to increase in prevalence. And we don't see that in adults over such a short period of time. Next slide. Now, our biggest challenge in the treatment of depression is that there's a bottleneck affecting treatment responsiveness in young people with depression. So what we know from the two latest and probably the best clinical trials in depression is that only about 40% of kids who are in a manualized treatment program with or without medication respond to treatment. So 40%, roughly 40% respond, 60% don't respond. This is another difference from adult depression. The response rate in adult depression is higher than kids, upwards of 60 to 70%. This response rate, 40% roughly, would be unacceptable in other mental or physical health disorders. You know, in ADHD, we have a response rate of about 70%. Asthma, diabetes, we have much better response rate. So a lot of us in the field are worried about and thinking about why is such a poor response rate in youth depression. And I think for me, the answer is that the treatments we provide don't take account of the complexity and heterogeneity of youth depression. Next slide, please. So this is one illustration of the heterogeneity in treatment response. So this is from a clinical trial in New Zealand, the so-called YODA trial. And what they've discovered is, and this trial was kids who were in cognitive behavior, receiving cognitive behavior therapy with and without medication. The addition of medication didn't make a difference. The point was, in this trial, was that there are basically two groups of kids in their response to treatment. There's one group called the improving group that shows a reduction in their symptoms by 4 weeks. And then they kind of plateau a little bit, but they continue to improve over time. That was about 55% of the sample. But then there's another group, which they call the persisting group, about 45% of kids who had consistently had high scores of depression, very little improvement over the 12-week period of the clinical trial. So not everybody improves at the same rate. There seem to be two different subgroups of kids with depression that respond to treatments differentially. We don't really know why, but it's really important to take account of that and to highlight for you that you can tell the difference by 4 weeks of treatment. So 4 weeks of treatment becomes an important milestone to make sure that the kids are improving. Next slide. So this problem of heterogeneity, I think, is ubiquitous in child and youth depression. You know, I talked about 9 different symptoms. You know, you can have almost countless different combinations of those 9 symptoms over time. And then there's all the comorbidity that we see with depression, ADHD, anxiety, substance use, autism. These can be part of the depression. They're going to complicate the heterogeneity. And then the reasons that young people get depressed are very heterogeneous. Many will get depressed because of trauma, many because there's a family history and a parent has depression. We know that poor sleep can cause depression in young kids. I've illustrated the importance of sex and gender, bullying. So there's all kinds of different reasons that kids can get depressed, and that adds to the complexity. And I think the problem is that the field has taken a simple approach to the treatment of a complex heterogeneous condition, either for the most part, either CBT or medication or the combination of medication and CBT. Pretty simple, given such a complex problem. And that there's a move towards personalizing treatment. And I think to get that response rate above 40%, we have to engage in some kind of personalization of treatment. The big question is, what do we personalize on? What clinical features do we use to tailor, to personalize the treatment program? Next slide, please. My friend and colleague, Dr. Darren Courtney, is a member of the Kundal Center, has put together what I think is a really neat slide illustrating that there are 4 key components to the treatment of depression in young people. 1, you have to provide an evidence-based treatment. Secondly, you have to include routine outcome measurement, or what we call measurement-based care. Thirdly, there must be a component of shared decision-making. And finally, having youth engaged in the structure and policies of the clinic as a whole is another important ingredient. And I'm going to cover each of these briefly. Next slide. So first of all, the evidence-based treatments. What evidence-based treatments should we provide to young people? The highest level of evidence are considered to be clinical practice guidelines. And so we went through an exercise a number of years ago trying to identify the most valid and trustworthy clinical practice guidelines for the treatment of anxiety and depression in young people. And we identified all kinds of different guidelines, and there was only one guideline that made it to the top. Only one clinical practice guideline that was considered to be trustworthy according to these critical appraisal principles, and that was the NICE guidelines from the United Kingdom. There are a lot of other guidelines that people use, but they're not as trustworthy as the NICE guidelines. And so I would recommend in the field of mental health going to the NICE guidelines if you want guidance. These NICE guidelines provide clues about how to personalize treatment, and I'm going to illustrate that next. In the next slide, please. Okay. I know this is a complicated slide, and I'm not going to go through it all. I'm just going to give you a high-level summary of this treatment algorithm, which we call an integrated care pathway that we think is very important to standardize the treatment of depression. The first thing is to have a comprehensive diagnosis and assessment, determine how severe the depression is, because there's an important treatment decision about mild versus moderate to severe depression. Everybody, all kids, should be evaluated, and exercise seems to be, a useful treatment for depression. Sleep hygiene, make sure that kids who are sleeping poorly, have good sleep hygiene. A balanced diet, the Mediterranean diet, appears to have some antidepressant effects, anti-bullying, looking for trauma. All kids should get these, and they should be addressed. And I would add here an assessment of self-harm as well. If there's mild depression, there can be sort of 2 weeks of watchful waiting. Don't need to implement a structured treatment program if the depression's mild. If they get better, great. If they don't get better, then enroll them in a psychotherapy of one sort or another. Just like the kids with moderate to severe depression, those are kids for which medication is appropriate, and I'll talk about that in a moment. But if you got if you have moderate to severe depression, a psychosocial intervention is important, and the intervention with the best evidence is cognitive behavior therapy, CBT, but also interpersonal therapy works for kids. The NICE guidelines also recommend family therapy and problem-solving therapy. So enroll them in the intervention for between 4 to 6 weeks, determine whether there's been a response or not using a rating scale. And then if there's been a response, great. If not, then reconsider if you should have another form of a psychosocial intervention. Next slide, please. When it comes to medication, there is only one antidepressant that has been demonstrated to be efficacious in the treatment of depression in young people, and that's fluoxetine. The evidence for the other antidepressants is very inconsistent and absent altogether. So if you're going to start medication, always start it along with a psychosocial intervention and start with fluoxetine because that has the best evidence for its efficacy. If after 6 weeks of fluoxetine you don't have a response, then you can switch to another antidepressant, and probably the best recommendation is to switch to sertraline, which is effective with anxiety, which is so commonly associated with depression. So a big problem in our field is that everybody's using all kinds of antidepressants for the treatment of depression in kids, and the evidence shows basically one antidepressant. And if that one doesn't work, switch to one other. And if that doesn't work, then focus on the psychosocial intervention as really key and important. Next slide. So just to highlight a couple of things as to what to look for at the assessment that it will allow you to personalize the treatment. I've emphasized the importance of using a standardized rating scale to differentiate mild versus moderate to severe depression, where you can think about using medication. If there's a risk of self-harm, you can identify that by family history. If there is risk of self-harm, you need to implement a safety plan. Dialectical behavior therapy is becoming more and more popular and evidence-based in the treatment of kids with depression and self-harm. Some kids will come where there's a family history of bipolar disorder, and if they do, you need to have in the back of your mind that using antidepressants will risk a manic episode in the young person. So you need to maybe add a mania rating scale to your measurement-based care. We underemphasize lifestyle factors in our treatment regimes, and the evidence does show that physical activity can improve depression, better sleep can improve depression, diet, evidence is weaker there, but diet can also improve depression. So paying attention to those lifestyle factors is important. And then if there's no response to treatment, here's where assessing the comorbidities, substance use, autism, ADHD, anxiety disorders, maybe those comorbidities will require treatment before you can successfully treat the depression. And then other risk factors that you might have identified during the formulation, like trauma or exposure to violence or war, including the bullying, racism, having those, if those are present, then having a problem-solving approach to the treatment and adding that might be quite helpful. Next slide. Self-harm is a very common problem, and self-harm, kids who come into the emergency room with an overdose or who have cut themselves or who have suicidal ideation, about 80% of them also have depression. It's a very common problem. Both what we call non-suicidal self-injury, so these are kids who cut themselves, not with the intent of completing suicide, but as a release of pressure, they are at increased risk of completed suicide many years hence. So we have this distinction between non-suicidal self-injury and intentional self-harm. They should really be considered on a spectrum, and any kid presenting with self-harm is at risk of a completed suicide later on. Other high-risk indicators are males. So males are more likely to go from an attempt to a completed suicide later. Kids who are, LGBTQ kids, gay, trans kids particularly, the more lethal the method, the higher the risk of completed suicide later on. Kids with substance use and self-harm, high risk of completed suicide later on. And family conflict, not such a strong predictor, but an important ingredient in focusing on treatment. The self-harm attempt is often precipitated by an acute crisis on the background of a long-standing depression. Next slide, please. This slide, which I showed earlier, illustrates the importance of monitoring response to treatment, because not everybody improves at the same rate. Next slide. And that's the measurement-based care, the routine outcome measurement. And I think more and more people are getting appreciate the importance of measurement-based care using validated what we call patient-reported outcome measures. Next slide. So what is measurement-based care? It is the systematic administration of symptomatic rating scales and the result during treatment, which measure response to treatment and allow you to modify the treatment plan as you go along. Next slide. There have been a lot of benefits demonstrated for the use of measurement-based care. The most important one I'll highlight is that you can identify by 4 weeks those kids who are not responding to treatment. And if they're not responding to treatment by that 4-week period, you need to reconsider the medication and reconsider the form of psychotherapy that you're using. There are a number of other benefits to measurement-based care that are outlined on this slide, but I won't go into them. Next slide. This is just some quotes taken from a study that we did on measurement-based care. And I just want to highlight how much the kids really appreciated filling out rating scales during treatment, and how much their caregivers appreciated filling out rating scales during their treatment program to see whether they're responding to treatment or not. Next slide. I think I'm going to skip over these 2 slides, this one, and then let's just go to this one. And I think there's a lot of questions that people have about what rating scales to actually use. It's important to use standardized rating scales that are sensitive to change. I've been engaged in an exercise with the International Consortium of Health Outcome Measurement that focused on what measurement tools and domains we should use in measuring in treatment algorithms for depression and anxiety. And the consensus of the group was that there are 3 important domains to measure: functioning, symptoms, and self-harm. So if you're going to have a measurement-based care battery of tools, pick measurement tools that measure functioning, symptoms, and self-harm all together. Next slide. So, yeah, these are the recommended rating scales that were identified in the ICHOM exercise. Again, I just put it up there for illustration. I don't know that they're available in Ukrainian. You know, the type of measurement tool isn't as important as the domains. The third essential component is that of shared decision-making. So at defined points, there needs to be a collaborative decision-making process with the young person as to whether the treatment is working or not. Next slide, please. Shared decision-making is this key collaboration between the clinician and a client in which the selection of treatment choice is based on both the evidence and the client's preferences and their values. And this is a key component in measurement-based care, where there's this discussion point every 4 to 6 weeks during the treatment process. It's ironic that clinicians think they engage in shared decision-making with the young person. Actually, they don't. Often their conversations with the parents or the caregiver rather than the young person. And in our experience, it's absolutely essential to have this conversation with the young person as to whether treatment's working or not, and what do they think about the treatment, how do they feel the therapeutic alliance is, what are their values about the use of medication, etc. Next slide. This is one of the most important things that I've learned in recent years, which is the importance of youth engagement in treatment. On average, a course of CBT is 12 sessions. On average, kids attend 6 sessions of CBT and then drop out. So keeping kids in treatment for the full course of treatment may be one of the major reasons that the treatment response is so low. So we really need to engage youth in our treatment pathways in order to make sure that they feel the treatment algorithm is meeting their needs. We and a number of other hospitals are setting up youth councils, youth advisory councils. So these are kids with lived experience who have been depressed in the past, say, or had another kind of mental disorder. And we pay them to give us advice on the setup of our clinic. Is it working? Is it not working? What could we be doing different? How can we be most helpful? And this is really becoming, the advice that we get really has made a difference in terms of engaging youth in the clinic and making sure that they stay in treatment. So it's something that I would really advise highly about making sure that youth are engaged in the administration of the mental health clinic. Final slide. Just to summarize, that the treatment of youth depression involves 4 components: an evidence-based treatment, measurement-based care, using standardized outcome measures, shared decision-making, and youth engagement. And careful monitoring of treatment response at 4 to 6 weeks, at 8 to 12 weeks, will really identify those kids who are not responding, and those who are not responding, has there been fidelity to treatment? Have they attended the sessions? Are they engaged in the therapy? If they're not engaged in treatment, why are they not engaged? And then can we shift course? There are other psychosocial interventions that I've mentioned briefly, like interpersonal therapy, problem-solving therapy, brief psychosocial interventions, family interventions to reduce conflict. All these can be useful addenda to include if the cognitive behavior therapy has not been effective. We have a website. The Kundal Center has a website where we have all kinds of tools for the management of depression. They're free. You're welcome to visit the website and to download whatever tools you want that you think might be helpful. Next, final slide is just a little bit about the Kundal Center, and keep that up there. And Miroslava, I just went over the 40-minute, the half-hour mark, but I'm ready for questions at this point.
Thank you very much, Peter, for an excellent presentation. So now we can begin the question and answer segment of our webinar. I invite you to post your questions in the chat at the bottom of your screen, and Dr. Zoriana Ivanyuk and I will select questions to present to Dr. Jatmari for response. So in looking at the screen so far, we have a very modest response. People have not yet posted questions. We really do encourage you to ask questions. Meanwhile, as we're waiting, perhaps Peter, you could just make a couple of comments on general comments on anxiety management. Would many of the principles you've outlined for treatment of depression be equally applicable to anxiety disorders of,
Yes.
again, as an overview, because of course they're very distinct in some of their presentations, but
Yes, anxiety disorders, the treatment is virtually identical. Now, there are some modifications to the treatment of anxiety disorders if anxiety occurs alone. So there's a bit more what we call exposure. Say somebody is anxious about going to school. Well, exposure to going to school can be a helpful part. It's still CBT, so it's just a variation on CBT. The one intervention that's different is obsessive compulsive disorder, OCD, but OCD is not an anxiety disorder anymore. It's been moved out of the anxiety disorder realm. But all the other anxiety disorders, social phobia, generalized anxiety disorder, separation anxiety, selective mutism, all CBT. If you're going to use medication, maybe the first one is sertraline, and the second one's fluoxetine. So that's where there's a switch between the medication for depression and anxiety. So, but still, and the principles of measurement-based care are the same. Determine whether there's a difference between mild versus moderate severe. Always provide psychotherapy for kids with anxiety unless they turn it down, and don't do the medication unless you've got psychotherapy as a backup. And that time period of response within 4 weeks, it's all the same. So very little modification required.
thank you, Peter. Okay, we have a few questions now appearing here. The first one is порадьте статті або літературу, де можна більше почитати про хронічний біль психолога.
Can you advise any references, any literature where a psychologist can read more about the chronic pain?
Okay. The first place I would go would be to the NICE website. Which is in the UK, and they do have guidelines on the treatment of kids with children and adolescents with chronic pain, and they do provide strategies for the psychosocial and sort of more comprehensive treatment of chronic pain. I know you're going to have a webinar on acute pain coming up. I would be happy to, I've offered to do another session for you folks if you like me. I hope you like me. I've offered to do another session, and I could do a session. I do a session on depression, anxiety, and chronic pain, and I'd be happy to do another session and include that.
Thank you, Peter. The next question is, Ви говорили про щоденний скринінг
You
стану
mentioned
дитини.
about the
Дитина
daily
має лежати
measurements
в
and
лікарні, чи
screening of a
лікування може
child.
бути
Is the
амбулаторним?
child supposed to stay in the hospital, or this could be the outpatient facility as well? Inpatient or outpatient?
You're going to have to do that again because I couldn't hear properly. Once more, please.
You mentioned that there is a need to have the regular daily screening, the measurements for the condition of a child. Is the child supposed to be in the inpatient form or outpatient as well can be expected?
Yes. So the measurement-based care, this is an excellent point. The measurement-based care that I was talking about was for outpatient care. So in other words, measuring either weekly or every 4 weeks. There's no rule as to how often you should do the rating scales as an outpatient. I do them actually every week. When they come for their appointment, I have them come early to the appointment, sit in the clinic, and fill out the questionnaire then. That seems to work pretty well. On the inpatient unit, of course, it's different. A lot of it depends on what's the average length of stay for your inpatient unit. But people are using measurement-based care on the inpatient unit, usually over the average length of stay in Canada anyway, for inpatients for kids is 2 weeks. I don't know what it is in Ukraine. I'd be fascinated to learn. So when we do measurement-based care on the inpatient unit, we sort of do it every 3 to 4 days, or some people do it every week. After a week of being on the inpatient unit, and then at the end of the second week, and if they're okay, they can be discharged at that point. Did I answer that question?
Yes, thank you. Another question here is, з якого віку дитині можна ставити діагноз депресія?
What is the age of the child after which we could diagnose a depression? After which age?
It's a very good question. This is a bit controversial. You can diagnose depression at any age. So after 5, 6 years of age, you'll see it's very uncommon at 5 or 6 years of age, and then increases rapidly at puberty. There are some groups, research groups, that say preschool depression is a lot more common than we think. I personally am a little bit skeptical about those results. I'm not sure, haven't been replicated widely by other scientists in the field. I think 7 or 8, it starts, you can measure it, 9 or 10 for sure, and start being vigilant 11, 12 for the diagnosis of depression. But definitely in childhood, but it's going to be rare in childhood. At least the current evidence would be that.
Okay. Another similar question. Як вік впливає на підхід до лікування? Бо є різниця між
Does
10
the age impact the
та
approach to
16-річними.
treatment? Is
Бо,
the
як на мене,
difference
деякі
between
техніки легше
16-year-olds
проводити з
and
більш
10-year-olds?
дорослими, бо
Because
вони
I
розуміють
think
краще їх
some
суть.
techniques are better fit the older children because they have better understanding of
So
how
you're-
to apply them.
So when Miroslava speaks and the translator speaks at the same time, I can't hear. So
Okay, sorry. So the translator can repeat.
So if just the translator can redo the question for
Yes,
me, that
I'm
would be
ready,
great.
please. How does the age impact the approach and the selection of care? Because there is obviously a difference between a 10-year-old and a 16-year-old. I think that some techniques are easier to apply with the older kids because they have better understanding of what to do.
Right. I think this is an excellent question. And I think in general, if cognitive behavior therapy is the first psychosocial line of treatment. The younger the kid, the more behavioral the treatment. So use more of the behavioral techniques of cognitive behavior therapy. And the older the kid, the more cognitive strategies can be used in therapy. Cognitive strategies like challenging their catastrophic notions, challenging being pessimistic, whereas younger, behavioral, make sure you get up in the morning, make sure you turn your cell phone off and you're not looking at your iPad at 10 o'clock at night, so it's interfering with your sleep. So more, make sure you get exercise when you're younger. So younger age, more behavioral, older age, more cognitive. I think you'll find that the medication seems to work better for older kids than it does for younger kids, although there isn't a lot of evidence for that. But medication more appropriate for older kids compared to younger kids. And I think those are the two sort of main differences. I think interpersonal therapy really hasn't been evaluated for children. It's an adolescent therapy, so that one isn't going to work. But certainly family therapy might be more appropriate for the younger kids, and problem-solving therapy might be more appropriate for the younger kids.
And just an extension for me, Peter, with the behavioral changes, does play therapy come in as being useful with a younger child, like 5 or 6 or 7?
No. So play therapy is not an evidence-based treatment for depression.
What would it be used for?
It shouldn't be used. It's
Okay.
not evidence-based for anything.
But yet it's widely implemented.
Yeah,
Okay.
well, that's a problem with our field, is that our field uses interventions that are not evidence-based. So, the kinds of psychosocial interventions for younger children should be focused on parent-child relationships. And improving the relationship between the parent and child, which involves a lot of work with the parent around having them to be more sensitive to the cues and communications of the young person and supporting their parenting, moving away from a critical, authoritarian parenting style to firm but supportive at the same time. I
Okay.
hope I haven't made I've lost some friends along that, but I'm reporting what the evidence is.
Okay. Another comment question. This one was in English. PubMed has many studies about the connection between sleep disorders and psychological disorders like ADHD, depression, PTSD, and they recommend doing sleep studies before going on with medications. What is your comment on that?
Yeah, we've done a lot of research in this area, and I don't think the only time sleep studies are necessary is when you are thinking about sleep apnea as the reason for the sleep problem, or restless leg syndrome, or if you think there's a medical condition that might be associated with the sleep problem. Most kids have difficulty falling asleep and have difficulty waking up. And the most common reason for that is a sleep hygiene problem. In other words, they've got their routine not aligned with light and going to bed and that cycle. So they have to get their sleep-wake cycle aligned with the light out there and melatonin things. So the first intervention, are you having trouble sleeping? Are you had difficulty falling asleep at night, staying asleep, difficulty waking up in the morning, sleeping during the day? That's most commonly a sleep hygiene problem. Are you snoring? Well, if you're snoring, then, if a 10-year-old is snoring, that could be sleep apnea. That would benefit from a sleep study. But most of the kids, it's hygiene and a simple behavioral intervention will be effective in treating that. And that will treat the depression. There's some evidence that treating sleep without going through all the medication and psychosocial intervention, if you start with sleep, you can treat the depression.
Okay, we'll go to our last question as we're coming to the end of our time. Is it possible that depression or OCD in kids will resolve by itself without medication?
Yes. So that is definitely true that it will resolve by itself, but there's a high likelihood that it'll recur within 6 months. So kids who respond to treatment, 50% of them will have another episode within a year. There'll be a relapse. So both OCD and depression are episodic disorders of adolescence. They come and they go. And the earlier they onset, the more likely they are to recur again. And so that's why providing an intervention is so important, because you can prevent the reoccurrence of another episode 6 months to a year later. And the more episodes kids have, the more it derails them from their appropriate developmental trajectory. And that will have poor long-term outcomes in terms of finishing school, getting a job, having a partnership, getting engaged in substance use, et cetera, et cetera.
Okay. Thank you, Peter. So that brings us to the end of our questions and answers. Unfortunately, again, you can submit any additional questions to the link that was provided in the chat, and we'll try to have Peter respond to them. Again, I want to thank you all for joining today's session. I hope you all found it useful. I certainly did. Our next session will be held on March 20th. At 4 p.m. Kyiv time. That's 1600 hours. And this session will be on rehabilitation of brain injury and physical trauma such as limb loss. If you haven't already registered, please click on the link that's provided in the chat that Laura has posted. And again, I want to thank you all for joining us today. Together, we will work together towards improving pediatric mental health care and making a positive impact in the lives of our young patients in Ukraine. So, дякую, and see you at the next session.